Thank you. Gentleman's time has expired, and now recognize the gentleman from Oklahoma, Mr. Hern, for 5 minutes.
Mr. Chairman, Ranking Member Womack, thank you for being here today. To the witnesses, Director Hadley, I really appreciate your time. I want to get right into some questions here. I've got like, 60 or so. The Democrats didn't ask for a price on this when they put it in the plan. I've read through your report, highlighted and made tons of notes. But going to the extreme of single-payer system, no private option, what's the anticipated cost? Do you argue with the 32 trillion, or could it be more? All in. Surely you've looked. You're a budget office. Surely you've looked at everything's all in, owned by the government, no private option.
But it still depends on the choices, the other design choices, such as cost sharing and critically how the providers are paid, right? So if cost sharing, or if costs were controlled through payment rates to providers, it could bring down costs sort of in two ways, both the direct effect and also if there was a shortage of providers.
So the narrative would be is that we would continue paying the providers less until we got to a point where we could afford it. Because I think you say in your report also that doctors, the reimbursement rates would go down, therefore the demand would overtake the supply, and doctors probably less likely to want to stay in a business where they're making less. And so then you also go on to state in the report that the government could step in and educate more doctors. So this is a gift that keeps on giving, where the government's more and more engaged in the process of making this work.
So yes, graduate medical education and how that's funded is one of the key issues that we highlight in the report.
And nobody's asked that question yet, by the way. Nobody's talked about how you're going to prop up the supply side.
And that's not the only way that could be done. It could also be done, there are some other methods one could pursue, for example, allowing physician's assistants and nurses to carry out services that are currently done by doctors.
So have less doctors and just keep pushing down the requirements. So we would sort of devalue the expertise we have in the medical field, people who have gone a long time to school to give us what some would argue the greatest healthcare in the world. And I know our friends across the aisle argue that, but we have people coming from these great countries like Canada and Europe coming here to have specialized treatments done because, as my colleague from Texas said, they can get it done in a timely manner as opposed to possibly dying before those procedures could be done. I've spoken to people in England who have the two-tier system, and when they have these immediate needs, because they can't afford it, they go use the private insurance and not the national health insurance.
That's right. In England, you can buy private insurance that helps have faster access to care.
And much of that's provided through these evil companies that are allowing their employees to actually buy that private health care. Is that correct?
Those are through public plan, or private plans,
Okay.
excuse me.
We also in there, you state that, quote, single-payer system could force compliance through an existing automatic payroll withholdings and taxes. Is that right?
That's correct.
Sounds like an individual mandate that we had in Obamacare, that when was removed, people made the choice not to actually buy insurance. Nobody kicked them off. They just decided they didn't want to buy it anymore. Is that what you could see happen as well?
So in the context of the single-payer system, what we were envisioning was that there would be taxes that would be withdrawn from the economy, not, but I see your point about a individual mandate.
So I've got so many here, but you also said that in there that about rural hospitals and about taking over the hospitals. Is it true that one of the driving forces behind negative profit margins in many of the hospitals is due to reduced Medicare reimbursement rates?
Yes, that's correct. That when the Affordable Care Act put in place a change in the way that those providers' payment rates are set, that it now includes an increase for the costs that they face and a decrease for the total level of productivity within the economy as a whole.
I really appreciate your work in this, and again, I read the report a couple times. It's safe to say that socialized medicine is and always been the Democrats' end game since go all the way back to 2000, and we can go a lot farther back than that. A one-size-fits-all healthcare comes with an unbelievable price tag that we've seen through reports, $32 trillion on the low end of cost of estimates over 10 years. Even without expanding Medicare from its current role, the Medicare Hospital Insurance Trust Fund will be insolvent in 2026. I support putting programs like Medicare and Medicaid on a fiscal sustainable path so it will be available for current and future generations. If we cannot afford Medicare as is, why are the colleagues making empty promises to the American people we could afford Medicaid for all? The problem with Medicare for all is it's the exact same problem with socialism. The system collapses on itself. And I'd ask my colleagues to be truthful to the American people and don't be, I guess, overtaken by the empty promises that big government, that this is not Medicare for all, this is Medicare for none. Mr. Chairman, I yield back. Thank you.
Gentleman's time has expired, and now yield 5 minutes to the gentleman